Welcome everyone to today's Pulmonary Fibrosis Foundation webinar. We are very happy today to have Robyn Mowery, who's the medical family therapist with Piedmont Physicians, Georgia, and the Ethics Committee co-chair at Piedmont Atlanta Hospital, and the Director of Healthcare Medical Family Therapy Integration at Mercer University School of Medicine, to join us today to talk about caregiving and pulmonary fibrosis. We've been planning to have a webinar on caregiving for some time, and we're thrilled that Robyn is able to join us and educate us and provide a lot of new and important information about caregiving. And I also want to mention that Piedmont Healthcare, where Robyn is from, is part of our Pulmonary Fibrosis Foundation Care Center network. I also want to give you a heads up. So welcome, Robyn, and why don't you take it away?
Okay, so it's my pleasure to be here. I was very excited to have the opportunity to work with you all. And so I'm going to just kind of dive in. I do want to throw out a caveat, which is that I have a Ph.D., not an MD or an RN, so I will talk in general terms about the medical things, but if there's anything specific about any patient's situation, they need to make sure that they're double checking with their physician. So just want to kind of make sure everybody's clear on that. So what we're going to talk about today is we're going to look at the kind of the review of what most people, I'm imagining, on this webinar are living with. So those are the things, the challenges, the burdens of just living with this very, very difficult disease that not very many people know about, and we'll talk about how that adds to the burden as well. So kind of a brief review of the patient burdens and focusing a little bit more on depth on what's going on for the caregiver. One of the main frames of reference that I'm going to use, and you're going to kind of hear me talking around over and over again, is that it's a reciprocal relationship. What affects patients affects family members, and what affects family members affects patients. And so it's understanding that circular nature of how families work that makes this both a difficult challenge, but also a great opportunity, oftentimes, for added closeness. So we're going to talk about what I call the gifts of caregiving and the care receiving, and I made this word up, relational fibrosis, because sometimes in our best efforts to adapt and cope, we can kind of get rigid, or we can get our own thick defenses up. And so we're going to see, hopefully, in this presentation how to avoid or minimize relational fibrosis. You have enough to deal with the pulmonary fibrosis. Finally, we're also going to, well, not finally, we're going to also talk about normative grief, and I call that nature's bridge for transitioning between how it was, how it is, and how it will be, and how that relates to anxiety and depression. And grief and loss is one of my specialty areas, and it's something I'm very passionate about. I worry so much that we forget that grief is normal. And so sometimes when we talk about it in terms of depression, we miss an opportunity to let nature do its very healing process. That said, we'll also talk about that there is real depression when you're dealing with such a severe situation and diagnosis, and anxiety about that. So I don't want to minimize that at all, but I'll focus a little bit more and just kind of filling folks in on the grief aspect of that. Because sometimes it's easier for us to kind of say, yeah, I'm grieving, and I'm not messed up, or I'm not inadequate. This is what I'm wired to do. I'm wired to grieve when things are lost in my life. And grief is so much more than just death and dying. There's loss of identity, loss of roles, loss of opportunities, loss of dreams, all of those kinds of things. So we'll talk about that. And then finally, we'll talk about the practical strategies and things. Hopefully, some tips from my 26 years of doing family therapy can kind of give you some ideas of ways to interact together. And then I've invited David, if he thinks about questions along the way, to jump in and kind of ask those. And hopefully this will be something that is of use to everybody. So away we go. Okay. So part one, patient and caregiver burdens, and what are your common concerns? So on each of these topics, I want to just start out with your takeaway points. And I really believe that when somebody has a serious illness, everybody struggles. But what we struggle with can be very different when we're the patient or when we're the family member. And what I think sometimes we tend to do is we tend to get into a comparison, and we tend to say, oh, well, they're suffering so much worse than I can't possibly, you know, I don't want to make it worse on them, or I don't want to acknowledge that I'm struggling. And the reality is everybody's struggling, and everybody is doing the absolute best that they can with the information they have in a moment, with the resources that they have in a moment. And so just being able to say, yeah, this is a good day for me as a caregiver, or a bad day for me for a caregiver, is just as valid as saying it's a good day for me as a patient, it's a bad day for me as a patient. And I think being real about that and letting go of guilt, I think guilt sometimes can just clog up the relational pipes. So when we're open with our vulnerabilities and share one another's burdens, we can endure more, and we often find those unexpected blessings along the way, because intimacy is about being vulnerable. So that's kind of what I want to actually have as the frame for us, just kind of now going through the specifics of burdens. So this was my list of burdens that I understood from the literature, and talking with like Dr. Amy Case. I work with her here in Atlanta, and we had some good discussions about pulmonary fibrosis. I don't think this is an exhaustive list, and I don't believe that every patient will have these exact same experiences, but just to run through them quickly. And David, if I've missed anything particularly for patients from any of these perspectives, please jump in and add those.
I will do.
But physically, you've got the apneas, the gasping, the choking, the hacking cough, decreased energy, the fatigue, you know, when getting up to, you know, comb your hair or brush your teeth or walk across the room to get the remote because you forgot to put it by your chair. It used to be you get to go up across the room to turn on the TV. You know, the reality is that our physical expression, our intimacy, that's a big part of our experience in life and in relationships. And so when we have decreased sex drive, that can be really tough. And we're going to talk some more about that at the end. Increased risk of other physical problems, health problems, heart disease, GERD, diabetes, pulmonary hypertension. Pulmonary, like when you don't have enough oxygen and that's flowing at a rate and with the amount that you need, that affects everything. And so we can have memory loss, and it can affect our focus and our concentration. When we start going through all of these things, it can alter our sense of who we are. When suddenly we go from, well, I was pretty healthy, and you know, I know I wasn't feeling that great, you know, because sometimes it can take a while for the diagnosis of pulmonary fibrosis. And then suddenly we get this diagnosis. It can really sort of throw us off. Who am I? How do I understand my sense of myself? And then as our daily life gets impacted and our work life gets impacted, you know, so many of us, you know, our roles as workers in our jobs, or as a parent, or whatever it is that our roles are in our life, those become a part of our identity. So that can get altered. That sense of self-efficacy, because so much about pulmonary fibrosis feels out of control and can be out of control. You don't know exactly when that hacking cough is going to come. And so there's a lot a lot of sense of things that used to come easy are no longer in your control, as well as the timing. And as part of that, any of us can get moody and irritable on just normal life, but then you add this additional complex illness into the mix, and that can make it harder too. Anxiety about what's going to happen. Where's this going? Am I going to be able to do the things that I want to do longer or shorter? And then patients worry about their family members. My experience working with families and patients for a long time is that patients don't just worry about themselves. They often, sometimes, and the research actually bears this out, they are sometimes more worried about the well-being of their loved ones, and that makes it tough as well. And then depression, and then embarrassment, carrying around oxygen, and you know, am I going to go to the movies, and and suddenly have this big uncontrollable hacking cough. So those can all be challenges. And like some of those, it impacts our social life. You know, we don't necessarily aren't able to keep up doing the golf or the tennis or whatever kinds of other athletics we might have wanted to do in the past. And again, when just walking across your room gets difficult, that can be a challenge. That withdrawal and isolation, you know, we do get protective of those around us, and sometimes it's self-protection out of that embarrassment, but also it's like, I don't want to spoil the movie for other people if I end up having that cough, so I think I'm just going to stop doing that. Or maybe I don't want to just, you know, I'm not going to go out to those fine dining restaurants anymore because of that worry. Excuse me, I have a dry mouth today. And then time and finances. It takes a lot of time to get back and forth to those doctor's appointments, and each of those doctor appointments is going to come with a bill at some point. Dealing with the oxygen supply companies and other durable medical equipment that you may need, you know, it takes time getting that set up, and that can be frustrating again. Time on hold on the phone, just trying to talk with somebody before they even answer. All that takes time. And then if we're not able to keep up at work and we have to reduce our hours, or eventually we have to stop working, all of those things have time and financial implications. So that was my list. David, any that you want to throw in here that in your experience we need to mention?
No, actually, I think your list is wonderful, and I love hearing you speak about this in a way that's not medical, not using many of the terms that, you know, a pulmonologist might use to describe what a patient is experiencing or to describe what the caregiver burden is. Actually, it was a little bit eye-opening for me to twist it around in my mind and hear this in such an important way that's not using that kind of intricate jargony medical terms that we all use. So this is terrific.
Well, I'm glad. That's good, because I don't always keep straight those medical terms, so and we can work together on that.
Great.
All righty. So kind of made another list. Again, not comprehensive, not going to apply to everybody, but from the perspective of the caregiver. Thinking about, you know, as folks get weaker, you might have to be holding on to folks as they're moving across the room, or helping them up out of a chair, and, you know, risks of back injuries, or, you know, moving oxygen tanks around. All of that takes physical exertion, and so there's some risks of physical harm to caregivers by accidents. And then, you know, when we start getting folks that are in their senior years, and a lot of times their caregivers are also dealing with their own health issues and their own frailties that can increase risks of trying to help somebody else. We know, and we're learning more and more and more about this body stress response system and how it is linked to so many problems in the body. And it seems like that inflammation is the mechanism that impacts so many organ systems and wreaks so much havoc in our bodies. So when we're dealing with all those physical stresses, psychological stresses, all of the stresses are on this list for both patients and the caregivers, it's impacting our own bodies. And then you're also risking additional medical consequences. Decreased quantity or quality of sleep. When I started hanging out with some pulmonologists and some sleep medicine doctors, it was very eye-opening for me how important it is to pay attention to sleep, and how that can create a cascade of other health problems. And so that's something I have appreciated from the pulmonology perspective, not taking sleep as lightly, no pun intended, as I used to. So that's a big problem too. And if we're not sleeping because we're worried, you know, or maybe we're awakened because of those coughs, those kinds of things, that can wreak havoc on us. Again, with stress, it can affect our concentration. It affects our ability to kind of remember what's going on. You know, I know when I'm under a lot of stress, I get flustered and balls get dropped and things like that. So that can happen to caregivers as well. Again, that psychological and emotional, as you're bearing witness to all that your loved one is going through on that other list that we just completed, it's hard to watch. And so often when we're looking at difficulties, sometimes we wish that it was us going through them rather than somebody else. How often do we say, gosh, if I could take that away from you, I would. Let me go through that, not you. And so that sense of helplessness that caregivers can feel, whether it's sort of overall or in those moments of just sitting through that fearful sense of shortness of breath, or those hacking coughs, or just watching somebody that's not able to go play that golf and that tennis game, and maybe have to watch it on TV, and looking at the eyes of their loved one going, gosh, I wish I could be out on that court, or wish I could be out on this green. That's a hard thing to witness, and that takes its toll as well. Again, as caregiver demands increase, oftentimes we have to let go of roles as caregivers. I used to be in the bridge club and I can't do that anymore, or I used to be on the PTA and I can't do that anymore. And so some of those other ways in which we express our identities can kind of get increasingly put to the sidelines as caregiving demands happen. Or gosh, I need to cut down to part-time work because it's actually more cost-effective for me to reduce my work hours than to try and hire professional caregivers while I'm at work. So you make those compromises, but I used to get a lot of affirmation from my job, and I kind of miss it, and it was a way that I got to be me. So all of those things can contribute. Being human, moodiness, irritability, stress can play havoc, anxiety, depression as well for the caregivers. Similarly to patients, that withdrawal and isolation, and it might be because, you know what, I don't want to go, I could go to my bridge club today, my loved one's doing okay, but I just worry, what if the moment I walk out the door is the time that something really bad happens? And so your social world gets smaller and smaller and smaller. And so at the same time, as caregiving demands increase and maybe you're not as social, so maybe you've let go of some of those folks that if you had run into them in the grocery store, you might have said, hey, yeah, could you help me with this? But you're not running into them anymore, and it just feels like it's too bold to actually call them and ask for some assistance. So our resources get smaller, and if we have demands of other kids, or maybe we're younger and we're still taking care of our senior parents. So our worlds get smaller as caregivers as well. And then similarly to the patient's list, time and finances, medical appointments. Again, now suddenly I'm going to my loved one's appointments in addition to my own. Those medical costs compound. Again, a lot of times it's the caregiver that becomes the case manager and trying to coordinate all those appointments and trying to coordinate when a doc's going to get delivered, and gosh, it was supposed to be delivered today, but it's not here yet, and we're almost out, and all of those kinds of things. And then again, impact on reduced income. So again, I throw that out. David, if you got any thoughts of more to the list.
I don't. I think this is really great, and I love how not only the content, but how you're speaking about it in almost what sounds like a personal way. It's very relatable. So that's great.
Well, I'm glad, because now we're going to get all sciencey on us. So this is more literature review related to ICU survivors. So it's not necessarily specific to pulmonary fibrosis, but as this disease state advances, or you do have these respiratory exacerbations, you can end up in the ICU. And so this is a summary, a literature review that really looked at the types of experiences that caregivers can come. And I'm not going to go, through all the actual data, but again, you can see that anxiety, even if it was a shorter ICU stay, months after the ICU stay, you still have a significant proportion of anxiety, of depression. Even into 12 months, you're almost at 50% of people still dealing with that depression. Post-traumatic stress or acute stress disorder, 12 months later, 80%. right? And PTSD is when our lives or a loved one's life gets threatened. And so when you're in the ICU and you're relying on that vent, hopefully for a very, very short time, and then we get you out and you're back at home. But it's a scary time, and it wreaks havoc. We've sort of mentioned, here's some data that talks about employment status. Up to 50% of caregivers reduce their work hours, quit their jobs, or were fired because they just had to leave the office because they had to take care of that emergency, or were late, or what have you. Financial impact, this actual data kind of brings some things home. 38% of caregivers in this review of the literature reported difficulty paying for basic food, housing, medical care, heating. Some had to move from their home. It might have been their home for a long time. Delayed educational plans, filed bankruptcy. Health-related quality of life. So we've talked about sleep, some of these others. Increases in their own mental health needs. And again, partly why we're doing this webinar, those emotional and relational problems can be a challenge for the caregivers as well. And then often says, well, I'm not going to take, I don't have time to pay attention to that little ache or pain that I'm having. So I'm going to just keep that to myself because my focus is on making sure that my loved one is taken care of. So they don't go to the doctors, or we don't go to the doctors. Medications. We start increasing use of medications when we're caregivers, or we take more of what we're already on. And that idea of the lifestyle interference, up to 12 months after discharge, almost 50% had to quit activities in order to take care of the patient. So again, some of the examples that we were talking about before. So I wanted to say at the outset, this is going to be very overwhelming, you know, and again, at the beginning, I really want to stress that part of what we're talking about here is that everybody has challenges, whether you're the patient or whether you're the caregiver, and it's just this is what we have to work together to deal with. And so not worrying about guilt over this. I know that's easier said than done, but every caregiver that I've ever met has said, I really, when it's all said and done, I would never want to be anywhere else. And so I think that's important. So we're also, part of this presentation is also to be encouraging and to say, okay, well, there's a lot that's out there that we've got to just have to deal with, but what are the things that we can do to make our lives a little bit softer and easier? Okay. No one chooses to have pulmonary fibrosis. Again, everybody's making sacrifice, and it's that deep sacrifices and that willingness to bear one another's burdens. That's love. You know, whether it's love between a married couple, whether that's love between an adult child and their parent, a sibling. It could be what I call family of choice, you know, that dear, dear friend that, you know, I've been living alone, and gosh, my dear friend is right there every day. They come over, and it's that exchange of sharing one another's burdens that I thought about it as, you know, that's what we have to exchange gases when we breathe, right? You know, both parts have to happen for breathing to be effective, right? We have to take in the oxygen and we have to get rid of the carbon dioxide. So we have to take in love from other people and allow them to love us and care for us. And then we also do what we can to care for other people. And sometimes we think, oh, well, if I can't do these physical things, then I can't provide care to other people. But that's where you got to remember, so much of what is valuable is just those conversations or that time present. It doesn't even have to be with conversations. I always think about those images of the married couple that have been together for 60 years sitting out on their front porch, and they're saying nothing to one another, but they're just there, and what a gift it is to be even in silence with one another. And that's that exchange. They're just sort of being in their lives as a part of one another. So I think those are the gifts. Caregiving's hard. Being a patient is hard, but it's also can be a beautiful thing. All right. So kind of ahead of myself a little bit, but this is whole next section of caregiving and care receiving, and I made up the word relational fibrosis. We've talked about that, I think, already. So takeaways that I want you to have in this section is that take the image of the mobile. You know, the little mobiles that you would hang under over baby's cribs. You know, if you've got the air conditioning on or there's a breeze, that mobile's always in dancing and in action. And the key idea is that every piece of that mobile, once it's in motion, it is moving other people or other parts of the mobile, and then that mobile, other parts, are then in return affecting that original piece that we were talking about. Families are like that. We affect each other, and we're affected by each other. And again, so much of what I'm wanting to emphasize here is that I'm actually wanting to invite you to think that some of the things that we do to kind of deal with illness is stuff that we have to deal with normal life anyway, right? So you don't show love to a 2-year-old the same way that you do a 12-year-old, the same way that you do to a 40-year-old, right, or a 60 or an 80-year-old. You know, the amount that you're kind of with them, the amount of independence that you allow them to have, that changes. Even the food that you eat. You don't eat the same thing as a teenager that you did when you were 2. And so sad, we can't eat the same French fries, you know, that we could as a teenager when we're in our 50s. So we're always making those adaptations and those changes to how we're living life, how we're relating to one another. So that's normal. And I guess I really invite you to think about all of those adaptations and those changes, how we care for one another changes just in the course of normal life. And then illness is just one more additional change. Is it a heavy one? Yes. Don't ever think that I'm trying to minimize anything about illness. It's big. It's hard. But I also want to give you the context that says you know how to do this because you've done and you've been adaptable your entire life. And so remember that those skills that allowed you to get through some of those other life changes, those are the same skills that are going to allow you to continue to get through all that you're facing with your illness, okay? And then pulmonary fibrosis and relational fibrosis. All right, so I ended up just saying a lot of what's coming up on the slides. But the idea of the mobile is remembering that the whole is greater than the sum of its parts. There's something that is above and beyond. You can't just separate out. Here's the patient experience. Here's the caregiver experience. You have to then say, okay, yeah, they do have their individual perspectives, but because they're connected together, what is the dynamic that gets created that's bigger than the two of them? And I'm talking about caregivers, though it's one person, and there may be a primary caregiver, but I also want to, for sure, acknowledge that it often takes a village, and we can have multiple caregivers, and we can have ones that are there for most of our time, but, you know, we have people coming and going as well, whether they're other family members, other friends, paid staff, all of that. So the big thing that I think becomes important around relationship issues is that idea of we're always in the mobile, both a cause and an effect. So what becomes really helpful about that is remembering that to get out of the blame game, right? How I'm responding to you and how you're responding to me is affecting one another. So we're both in this, so let's just don't worry about the blame game and let's just figure out what's my part, what's your part, how can we together work collectively to make things smoother. The idea of purposeful versus productive is I just fundamentally believe we all do the best that we can with the resources and information we have at any given moment. And so how we're trying to cope, the strategies that we're using, usually they're purposeful strategies. We're trying to accomplish something good in them in that moment. And it might be, I'm just so frazzled, I just need to just vent for a moment. Or it might be, you know, I just need time for myself. Whatever it is, there's a purpose that's usually a good purpose behind it. However, sometimes our strategies aren't all that productive, okay? So when we can pay attention to, even if the strategy itself isn't all that productive, rather than only getting mad or frustrated with the actual strategy, when we can focus on, okay, what was trying to be accomplished there? Because if we can get in touch with what the purpose was, maybe we just need to honor the purpose but come up with a different strategy that's more productive. So I think that distinction can be helpful as well. When I first started thinking about this, the story by O. Henry came back to my mind, and it's been around since 1905, and I just want to kind of give a brief synopsis here. But it tells the story of this couple, and just poor can be, and they had nothing and really no income, and they had each of them had one prized possession. The husband had a watch. It was a pocket watch that he had gotten from his grandfather or something, and that was his pride and joy. Everything else in his life, you know, was not valuable to him in that sense. It was just this one thing of tangible value. And for the wife, she had the most amazing, long, beautiful, luxurious hair. And so it was a source of pride for her. And then there came a holiday, and they wanted to give each other a gift. But what do we have to give? We have no money to go out and buy these gifts. I am looking at these things that I really saw. I did see them in the shop. I want to get them, but I don't have the money. What am I going to do? How am I going to show love to this person? Well, what the wife decided was that, you know what, there is such a beautiful pocket watch chain that I saw in the shop. I don't have enough money for it. And so I really want to get that for my husband so that he doesn't lose his watch. His pocket watch doesn't just slip out of his pocket and he loses it. That would just be devastating. But I really want to get him this chain. All I can think of to do to show him love in that way is to cut off my hair. It's my one true beauty and one true joy, but I love my husband so much that I'm willing to sacrifice what is so important to me because I want to do this for him. Well, unbeknownst to her, in the meantime, the husband had been walking by a shop, and he'd seen these beautiful, beautiful combs, hair clips. And he's like, oh my gosh, those are so lovely. That would just so highlight my wife's hair, and I know she would just feel so special and so beautiful with these combs. I don't know how I'm going to get them for her. The only thing I can think of to do is I'm going to sell my watch. So he sells his watch, and then comes the holiday, and they're exchanging gifts, and they're opening up one another's gifts, and they realize what has happened, that each has bought a gift for this thing that actually got sacrificed. And in that moment, now suddenly they don't have their prized possessions, and they don't have the gift that they were intending, but what they got out of that instead was such a profound sense of being loved and being cared for and caring. And so that, I kind of keep repeating this theme over and over again when we talk about caregivers and we talk about patients, receiving and giving. That story, I think, really emulates that, because sometimes the gifts aren't the tangible gifts. They're the relational gifts that we give to one another. So we can't cure pulmonary fibrosis. Oh, so much. All of us wish we could. But how we deal with the presence of that illness in our lives, we can minimize those rigid relational patterns and emotional scarring, which is what I'm calling relational fibrosis. Relationships are hard. Even when they're going well, they are tough. And so we step on each other's emotional toes all the time. We cause wounds that we don't even mean to cause, or we just lose it on one another. And those non-productive ways of coping kind of have fallout on those that we love. The key to that is to not let it fester. Just like you know with your illnesses that, you know, if you've got a wound and you leave it open and exposed and don't attend to that, it can fester and get infected, or it can become an abscess inside because it's not the source of the infection hasn't been dealt with, addressed, and you know, and it's that infection control, and then that wound creates scarring, and then now you've got even deeper. I think about the surgery. You know, you go in and you do one surgery and that was great, but if you have to go back, now you're having to actually cut through that additional scarring, and that makes the next surgery even a higher risk. So how we're interacting with each other, are we increasing or decreasing our defensiveness? Are we decreasing our defensiveness and increasing our intimacy? Are we getting stuck in these patterns? You know what, I can't deal with her nagging anymore, so I'm going to just withdraw more and more. Well, you know what, I'm not even going to listen to her. Well, you know what, I wouldn't have to nag if you would just come talk to me, you know, or if you would just do what I wanted you to see. We can get into that dance that we call it the pursuer distancer dance. And it's our doing our best to cope with what's going on, but coping in a way that we can get stuck in these relationship patterns. So our scarring can cause our own thickening in our relationships and make it harder to do that in and out, giving and receiving of care and concern and love. So keys, being willing to be vulnerable. It's hard talking about stuff, but if you can take that risk to be genuine and real and be willing to share what's on your heart and what's on your mind, that can be really such a gift that you give to your loved one. But sometimes the more important gift is being willing to listen to the other person. So you don't have to agree. A lot of times we don't need people to agree. We just need people to hear us. We can have different experiences. We can have different points of view. But can you hear how important this is for me? And it's that willingness to be creative, flexible, and adaptable like we've been talking about. You've been doing that in all kinds of ways throughout your life. So doing that as you're trying to deal with this as well will keep you fit in your breathing of relationship.
Hey, Robyn, sorry, can you go back to that slide? I just want to know.
I'm fine.
I just want to emphasize, so I have not heard the term relational fibrosis before. So you created this term, is that correct?
I made it up.
This is such a great term, and thinking about not only my own patients but other people with pulmonary fibrosis that I've interacted with, and what everyone goes through between, usually in the family unit, but obviously it can be beyond the family unit with the caregiving relationship. That idea that the disease is, getting in the way, changing the relationship, and that each of our own, quirks and who we are and how we deal with things interact to, to lead to this relational fibrosis, on an interpersonal level. And then to see these three bullets at the bottom, the three keys, obviously are hard to do. We all think about our own lives and our own personal relationships, and the idea that we need to be vulnerable and to be able to talk openly about what we're feeling and thinking, and to be flexible, how hard it is for so many of us, myself included, to be flexible and adaptable. But for the listeners, I would say if you only remember three things from this whole webinar for the rest of your life, I would say remember those three bullets down there. Those seem to be keys to success in my mind.
Mm-hmm. Well, and I think, just as you're talking, I can barely speak any time without a metaphor, so they just kind of roll out. Sometimes they're good, sometimes they're not, and sometimes I mix them. But with this one, as you were talking, you know what? You had to take that challenge, as a patient, when our lungs internally aren't able to do what we need to do. We had to put that on the outside. We had to put that oxygen on the outside. Well, just like our feelings and our emotions, sometimes we got to get that on the outside, because then that's what's going to keep us healthy and keep us going. As you've maneuvered, figuring out how to be creative and flexible and adaptable, dealing with that oxygen tank, or dealing with, some of those other challenges that were listed at the beginning, just as you've had that capacity to figure that out and take those risks and learn new ways of being in the world to deal with your physical illness, you have that capacity to do these new things. You have those capacities to be vulnerable, to take risks, to be flexible and adaptable, and you're proving it every day as you're working on your physical illness. So again, there's a lot that we can go back and forth. We just have to put those connections together. That it's not as foreign as sometimes we think it is. But that said, it's not easy either. So I'm going to keep moving because I glanced at the clock here. So Grief, I talked a little bit about this at the beginning. One of the key messages is that there's not a right way to grieve. Each individual grieves differently. I could spend a whole grief is actually my clinical specialty, and I'm just next week finishing teaching an entire semester graduate class in grief and loss, so I could go on and on and on for that. But key thing is that keep it moving. As long as it's moving, it doesn't matter how fast it's moving. It doesn't matter how it's getting expressed. Some people are going to express their grief by, writing in a journal. Others are going to express grief by, when they're able to go play basketball. Others are going to express their grief with their best friend, and and there can be tears. Or others, it can be just, just taking that quiet car ride and just kind of acknowledging that things are hard right now. Not a right way to do it, but doing it is what's important. We're going to talk about ambiguous loss, and a lot of people don't know about that, and I'll define that in a minute. But what becomes important is that it's paying attention to the ambiguity of the situation that's the problem. So much of the time we take it as though, oh gosh, I'm not coping well, or I'm not resilient, when actually it's like, well, gosh, considering what you're going through, it seems like you're coping pretty well. And then another term we'll talk about is disenfranchised grief. And when we don't accept or others don't understand what we're facing, sometimes we can not allow ourselves to grieve fully, and so we kind of keep it all in the inside. And what I'm understanding from talking to folks that are working with pulmonary fibrosis patients and families all the time is that it's a more rare illness, and so people don't understand it. And I was reading about, especially at the beginning of the illness, when it doesn't seem, you don't have all those outer signs of being sick, so does it get minimized? Are you minimizing it because you're like, well, this is no big deal, or it is a big deal, but I don't think it should be, so now I'm getting in this loop in my head. So we kind of create that disenfranchisement, so we don't count it as valid when we have these feelings. So that we're going to talk about that in a minute. So again, normative grief, nature's bridge. We're designed for grieving. Research shows that there is grief on every culture on the planet. Now, how people show that grief and express that grief can vary widely across cultures. It can widely vary across genders. It can widely vary across individuals. So, but the fact that everybody's grieving in some way, we know is a human thing. And then one of the things I really encourage people to think about, so often we think about grief only when we're talking about death and dying. Well, there's losses of dreams. There's losses of capacity. There's losses of routine. I don't get to go hang out and see my friends every day like we were talking about earlier. So there's a lot of losses. Those losses of identity that we mentioned. Allowing ourselves to grieve those instead of blaming ourselves or thinking there's something wrong with me, or it gives us a permission, and when we understand it as grief, it doesn't feel like it's so pathological, because it's not. It's how we got wired. And so I really want to introduce that concept. Ask first, is this grief, before assuming that it's depression. Okay, now grief and depression and somewhat anxiety can overlap, and they do. And oftentimes when you don't allow yourself to grieve, it can kind of get stuck and lead to some of these other more clinical difficulties. One of my passions interacting with docs is, with the white coat, you got a lot of authority as a medical provider, so give permission to grieve, validate, normalize it, maybe delay that prescription for an antidepressant a little bit. I'm not saying take it off the radar altogether, because it may be necessary, but maybe delay it a little bit and see what normalizing grief can do for that person, and allow them to move through that. It's also very empowering. So just a thought on that one. There is some research that suggests that when you prematurely medicate depression, you're short-circuiting that ability of grief to do its healing work. Okay, so we kind of talked about the importance of just keeping it moving. So this is how it kind of come to think about it, you know, pulmonary fibrosis, we don't have a cure, and that is just heartbreaking. And so when we get that diagnosis and we've been diagnosed with a serious illness, and we know that it's progressive, and we know that it's we don't have a cure for it right now, we have to make a whole lot of mental adjustments. And whether we're the patient or we're the caregiver, I believe, and again, this is just Robyn's world way of thinking about things, I sort of see there's sort of a progression that we all go through. Sometimes we go through it very quickly. Sometimes we go through it very, very slowly. But we all know that we don't get out of this life alive. And so we all know that at some point in our life we will be facing our death. But when you get a serious diagnosis, suddenly that thing that was always back there that we knew, but we never paid attention to, oh my gosh, it's on our front radar now. It's possible. And, you know, now it's progressing. Gosh, it's probable. Oh gosh, the illness is really progressing. It's really inevitable, and it's inevitable soon. And now it's here. It's imminent. And then for the loved ones, not only is death past, but their loved one has passed. And so I think that one of the things that happens in relationships is that we tend to think that our grief and our adaptation to these markers happens at the same rate for everybody. Or if I'm understanding this at this stage, then you should understand it at the exact same stage. And unfortunately, it doesn't work that way. And in families, we all grieve at different rates. We all adjust mentally and cognitively and emotionally to each of these different things at different rates. And so allowing people to be at different stages of this process at different times is a way to kind of, again, add grease to that relationship. You don't have to discount where you're at with it, but it also permits other people to keep moving along at their rate. Okay, mentioned ambiguous loss and disenfranchised loss or disenfranchised grief. Ambiguous loss came out of the work by Pauline Boss at the University of Minnesota, and she started this work actually and developed this concept with prisoners of war. She's been involved with, you know, a lot of like the 9/11 traumas and things like that, or dealing with dementia. And the idea of ambiguous loss is when a person is physically present but psychologically absent, or they're psychologically present but physically absent. And now I want to kind of gently apply this to pulmonary fibrosis, right? So because as we're going through all these identity changes, all these different losses, we can kind of be in that process. So I can sort of be doing some of the activities that I used to, but not always. Or I can some days and I can't some other days. And so I don't know if I'm the person today, the same person today as I was yesterday, or if I'm going to be the same person tomorrow, depending on what is happening in my illness. So I'm extrapolating a little bit out beyond the research literature, more as a conceptual application. There's no research that talks about ambiguous loss that I'm aware of related to pulmonary fibrosis, so I want to be really super clear about that. But I think when we're dealing with transitions, the idea of having to be in this constant transition is that things get ambiguous, and things are not clear-cut, or roles are ambiguous along the way. And so it makes it harder because you don't know exactly what you're dealing with at any given moment. So if we remember that's our circumstance, then sometimes we can be a little bit kinder to ourselves and say, wait, okay, it's not necessarily me, it's the ambiguity of the situation. And then we slowly work up that tolerance to say, you know what, I hate it. I really like knowing what's going on for sure. You know, I'm one of those people who likes things nailed down. I have to acknowledge and recognize that I can't have that certainty about all these things, and some of it's going to be ambiguous. And so it's developing that tolerance and just acknowledging it as the circumstance instead of assuming that there's something wrong with you for how you're coping with things. And then we kind of mentioned that idea of disenfranchised loss and grief. Be kind to yourself. It's a rare illness, and it can be so easy to feel like, gosh, nobody's getting it. I'm so alone, and so, well, since people aren't making it explicit that I'm going through all this loss and grief, then maybe I'm really not. And so that's what I want to do, is I want to, would the word be refranchise you? To just give yourselves permission. You're feeling what you're feeling, and you're feeling it for really, really, really good reasons. Okay? All right. Now, in our last 9 minutes, I'm going to kind of throw out some of these practical strategies. And so well, I'll just do what I've been doing. Okay, key points. This comes out of narrative therapy, and I love this. It's called "The Person's Not the Problem is the Problem." And David, when you were talking earlier about, you know, the role that pulmonary fibrosis has, I'm immediately picturing this slide and knowing that I'm going to get here, because what you said earlier is exactly what we're talking about. And it's recognizing that if you go back to that mobile idea, and if you have one little, you know, piece of the mobile is each of your family members, well, guess what? When you get a serious diagnosis, it's like adding another member to your family. And that diagnosis, everybody forms his or her own relationship to that diagnosis. So the patient's going to form their own unique relationship with that diagnosis. The primary caregiver, the kids, the parents, the siblings, you know, everybody, the friends. So suddenly it's the illness that is also shaping the dynamics about what's going on. And when we can separate out that it's not you, Sam, you know, it's the illness, sometimes we also can kind of find that inner sort of grace and patience that when we think it's the person, we don't always find. We're going to talk real briefly about some research that's out there. Probably won't go into detail now because we're short on time, but teamwork is everything. Just like if you've got that new member of the family, that the PF is a new member of the family, we got to figure out how we're going to operate as a team. It's not going away. We wish it would, but it's not. So we got to acknowledge that it's not going away, and we got to figure out how do we coordinate and be cohesive together on how we're going to deal with things. So again, that same theme of everything in life, we kind of keep making these adaptations to, and so we need to keep that idea of movement, that idea of flexibility, and knowing that we came up with a strategy that might have worked great early on in the illness. And now as things are progressing, we got to come up with new strategies. And I think if you think about them as strategies, you know what? We all are developing strategies every day of our lives, and we change them as we need to. So I encourage you to think about coping in terms of saying, okay, what strategy is working for me today, or do I need a new one? And then the final thing I want to just kind of end on is, because as I was reading, I was hearing and reading that, you know, there's this unspoken topic about how to deal with sexuality. And so I just want to kind of name it, talk about it, get real for a second, and just acknowledge that that's a real issue. So let me kind of run through these. All right. So the person's not the problem is the problem. We just kind of talked about that. Another quote, it's one of my favorites from family therapy, is no problem happens 100% of the time. What we do is we get what's called problem-saturated stories. So our brain is very efficient, and so our brain is going to go, oh, that looks familiar. I'm not even going to spend a lot of time thinking about that. I'm going to just put it over here, and then I'm going to use the same old responses, because our brain is amazingly efficient in that way. But that doesn't mean that the brain hasn't also been collecting data about other times when the problem wasn't there. But because we train ourselves, not consciously, but we just happen to start paying attention to when the problem is all the time, we forget that our brain has all this other data, all these other resources about when the problem wasn't there. And so if we shift our focus to saying, gosh, what was I doing or not doing that contributed to the absence of the problem? Now, we're not talking about the absence or presence of pulmonary fibrosis, but we might be talking about the absence or presence of that withdrawal or distancing dance that happens. So I really want to encourage you guys to think through, you know, what is it that we're doing, that dance, that when is our dance really good? When are we able to sort of troubleshoot and problem solve in a way that's smooth and cohesive? When have we been successful? And it doesn't always have to be about an illness or the specific things. These are a lot of translatable skills that I want to encourage you. Look at your life and find those other successes and say, I wonder if I can translate that, and let's try when we were really good at doing it in that scenario. Do you think if we really kind of broke down the details and tried it over here, we could? And what I think is so powerful about that is because you're looking at what you've already lived and breathed as successes, which is very different than picking up a book and saying, oh, okay, here's my stress management strategy for the day. It's much more organic to say, gosh, I've already been doing X, Y, or Z. I know I can. So now all I have to do is take those same skills that I know I've been successful at, that we've been successful at together, and apply them in this new way. So that's something I imagine I want to invite you guys to think about as a practical way to look at what else is in your brain that your brain's been paying attention to, but you're not paying attention to. Okay. So returning to the side of the problem's not the problem, the person's not the problem is the problem. One of the things that is key and helpful to do that, and David, you did it perfectly, when you said when the disease is there. So it's changing our language and starting to talk about the language as that additional member of the mobile, and saying, you know what, I am really mad at the PF right now, not you are really making me mad, loved one. And so I think if you sort of practice that idea and just imagine them as another character, as another part of your family, and you're in relationship with that illness, I think sometimes that takes a lot of the heat. It takes a lot of the blaming and the shaming that we can get into, that just because we're worn out and we're stressed. Now, a fun thing to do, you can call it pulmonary fibrosis, or create your own name. Sometimes if you find a name that might be even a little bit silly, it can, in that moment, cut the tension if you guys are struggling. So I'm trying to figure out like something for the acronym IPF, right? So I came up with intrusive pufferfish. Now that may be really, really lame, but then in my metaphor brain, started thinking about when we get defensive, what do? We puff ourselves out to make ourselves look bigger, and then that distances us from other people. Or maybe a closer one is the idea of the breath thief. It's the breath thief that is getting between us in our relationship right now. All right, this is the research that I'm not going to have time to go into a lot of depth about it, but it's there. You can maybe review the slides later. The big takeaway is that this extremely well-designed, gold standard research study dealt with not just a caregiver, but multiple members of the family as well as the patient from the time of diagnosis of a serious illness all the way through. Some continue to get aggressive care. Other people went a palliative care route and then followed the multiple family members through a year past into bereavement. So out of this research studies, and it's a whole collection of research studies, multiple things contributed to positive bereavement outcomes, but the number one that was the strongest of those multiple things was the perception of overall family coping, and really that comes down to operating as a team, and that idea of ganging up against the problem, not the person, working coordinated and collaboratively. Cohesiveness, conflict resolution. The existence of conflict is not necessarily unhealthy, but it's being able to resolve that, and that communication of expressiveness and communication that we talked about. So winding down, sex is okay. It's okay to talk about it. It's part of being human. It's part of being in relationships, committed, close relationships, or however. And it's okay to talk about it. It's okay to talk about it with each other. It's okay to talk about it with your doctor. That's that vulnerability stuff again. Talk about your fears related to stamina, or gosh, is she going to be turned off because I have this nasal cannula? Or gosh, I don't want to move in that way, or even though we used to, I just don't want to hurt him or her. So talking about those things with each other, putting them out there, allows you to then cope with them and create strategies that are often more productive than not talking about them. Talk to your doctor about how to adjust oxygen levels. Some of the things I was reading online, and I have to defer back to the medical professionals for the details, but I was reading about if you have to use oxygen during regular exercise, go ahead and use it while you're being intimate, not just trying to recover afterwards. But again, have that conversation with your doctor about the specifics, or he or she, as a doc, may come up with even better suggestions. Read online some ideas about positions that can be less harmful, that still allow you to have that closeness. And then remembering that sex is more than just that ultimate act of intercourse, that it's holding each other's hands, it's caressing, it's being real and open with each other, it's taking baths together, it's cuddling, it's having the hand around your shoulder as you're sitting there watching TV. All of that is physical intimacy, and it becomes important. And so I just really want to encourage you. I want to just name it, put it out there, and say it's okay to talk about it. It's perfectly normal. And then my last end statement, bottom line, is that you're not alone in this. So how did I say it? You are not in this alone, so be in it fully together. And that's really the message that all of this is driving at. So that's it for me.
Thank you, Robyn. Yeah, that was just terrific. I honestly, I actually learned a few things myself, or at least how to talk to my patients and their caregivers a little bit better about things. So this was really wonderful. So everyone listening, we will in the short term put this up on our website, archiving it so you can view it again or share it with friends and family. We are going to hold a webinar probably in June. We'll be releasing the date soon. The next webinar will be an Ask a Doctor webinar, because we've already received a lot of questions on many topics, and we're going to bring the medical team on board and hold a webinar. So you'll be hearing more about that in the coming weeks. And Robyn, I just want to thank you again for delivering really a wonderful and I think very useful and practical webinar for our community. So thank you.
Absolutely, my pleasure. Thanks for the opportunity.
Sure. And everyone at home, thanks for joining us. Bye-bye.
Bye-bye.